Okay, let's look at nephrotoxic agents. Okay, we'll leave it at Friday. If anybody feels like that's really a hardship, just email me and I'll work it out with you.
Well, what do you mean about the capacity?
Pardon?
That's not
I was
what they
just
mean.
offering options.
What was your option?
Doing it.
No. Okay, nephrotoxic. So this is drug-induced kidney disease. There's a lot of drugs that do that. I'm going to talk about some of the bigger ones. Most of the time, it's reversible if you remove the offending drug. There's only one or two where it's not. The biggest thing is prevention. So when you're using nephrotoxic drugs, one thing is recognize it. The other is to recognize what other risks the patient may have for the nephrotoxicity. If you're using multiple nephrotoxic drugs, then the likelihood goes up. If they're dehydrated, the risk goes up. So trying to take steps to reduce that will help. Using the appropriate dose. So we're going to talk about creatinine clearance, and we're going to talk about dosing drugs based on a patient's renal function. Those are the things that will help prevent them. We can kind of group them into what they end up doing. The first two, there's about 5 or 6 drugs under this category, a common problem that drugs cause. So a lot of drugs can cause acute tubular necrosis. It's a direct toxin. Either it's going to kill off the cells, or some of these drugs concentrate in tubules. And so once the concentration gets high enough, like with aminoglycosides, it just kills the tubules. Some of them will lead to renal ischemia, and then the pursuing problems that we talked about from there. If you look under there, the one thing that's common is that it's the results. So you get a cellular debris-filled muddy brown. Did they show you pictures of it? Okay. Granular cast in the urinary sediment. So when you get a urine specimen, or if you're looking at their urine bag, it'll float to the bottom, or settle on the bottom. Aminoglycosides, not a drugs we use very commonly anymore, but they're still very good. They're great gram-negative drugs. Use them in the hospital. We talked about them in HENOT, but the topical use is not the worry. It's the IV use. So these, in 10 to 20% of patients, that's high. Okay. This drug is filtered by the kidney, concentrates in the proximal tubules. So that's where it usually exerts its toxicity. It's a delay, so that's one thing I would mark, is that you need to recognize it's about 5 to 10 days out. You're going to follow serum creatinines when you have somebody on aminoglycosides, because usually you'll see it progressively start to rise. So there's some recommendations, usually more than 0.5 to 1 milligram per deciliter. This is different than what I gave you for AKI. More, I'm telling you, this is what you're likely to see as a result of toxicity. Or their plasma, or their creatinine, just their serum creatinine goes up. This is a drug that can be monitored with serum concentration, so that would be one of the things you would do. Renal function, serum concentrations would also would help in terms of preventing this. Lab findings: mild proteinuria, because you're destroying filtering ability, and you get bigger windows that allow bigger molecules through, and so those Bowman's capsules they're right there next to the proximal tubules, they get affected, and so proteins start to come through. Hyaline and granular cast. Also, the fractional excretion of sodium goes up. So did you all talk about?
A little bit.
Okay. So you won't have to calculate. There are calculators. If you needed to do it and you had the data, you could calculate it. Your lab should do it as well. So your fractional excretion of sodium is looking at urine sodium and serum creatinine. So you're looking at how much do the kidneys actually secrete that gets into the urine. It's by far a better indicator than your serum creatinine or serum sodium or urine sodium alone. Okay. So here it's a increase above 1%. Other findings, they lose the ability to concentrate their urine, so they will excrete a very dilute urine. Magnesium can also go wrong. Usually full recovery takes some time. Stop the drug, usually about 3 weeks. Those time frames I would want you to know. Risk factors, dosing it too aggressively, which would mean giving them too high of a dose. So usually when we're using an antibiotic, we're going to look at the MICs, what's a minimal inhibitory concentration. We know the serum levels that will accomplish that. By monitoring that, we can keep them within a range that gets us therapeutic, keeps us out of toxicity. Other nephrotoxic drugs. These drugs, you rarely use aminoglycosides by themselves. So often, IV antibiotics are nephrotoxic. Vancomycin, a big one, and it's coming up next. Combining those two together, it's about a 40% risk of nephrotoxicity. So how to prevent? Can you use something else, especially if you've got a high-risk person? Don't let them get volume depleted, because ischemia can then cause you trouble. Monitor serum levels, monitor renal function. That should be fairly intuitive, I'm thinking. Vancomycin, another one. Usually reversible, can cause long-term trouble though. The nephrotoxic potential is 5 to 15%. That's a significant number. Think about the people who get MRSA. They are usually sick, so they are compromised multiple ways, and so their risk for renal problems or renal effects are high. This slide just kind of takes you back to things we've talked about before. Remember, one thing we're always shooting for with antibiotics is we want to get to steady state. And with steady state, we are going to have these changes in plasma concentration of the drug within a range that keeps them out of toxicity, but keeps them therapeutic. So here, when we're looking at these, when we're drawing drug levels, we're going to talk about troughs and peaks. Troughs are the concentration right before, or what's the serum concentration right before the next dose. Okay? With vancomycin, that's what correlates with nephrotoxicity. So we're going to be monitoring troughs. You don't need to worry about the peaks because we know they'll be high enough. You'd only do peaks if you were worried about, are you getting enough drug into the person to kill the bugs. We're not worried about that. We know that will happen. So with here, we're going to monitor troughs. I think it says troughs above 15 micrograms per deciliter. Is it deciliter or liter? Milliliter are more likely. That is within therapeutic range though. So you're going to have to pay attention to who's at risk. Other nephrotoxic drugs. They're also on aminoglycosides. We're worried. Total daily dose, large dose, 4 grams. That's a fairly good size dose. So keep those 2 antibiotics in mind. Another very common is radio contrast dyes. We use them a lot when we take people for studies so that we can light up areas of the body that we want to see. Renal ischemia, direct cellular toxicity. That's why they cause ATN. Usually this occurs fairly soon after they've had the study, 24 to 48 hours. You're always going to monitor these folks. You're going to try to take them off nephrotoxic drugs before you send them for a study. You're going to hydrate them well and watch them for a day or 2 afterwards. Serum creatinine peaks in about 3 to 4 days. You see it's a little bit behind, and then it will return to normal, hopefully in about 7 to 10 days. Here, that appearance of the sediment is the same. Here, the fractional excretion of sodium is low, so not elevated like we saw with the aminoglycosides. Risk factors, pre-existing kidney disease. So they've defined that as a GFR below 60. Now that's, most of your adults, older adults that have got chronic disease, that's where they will live and below. So that will be not uncommon. People with heart failure, again, it's because you're messing up that autoregulatory areas of the kidney that keep their kidneys working. Prevention, use the lowest dose that will get you what you want. Use a non-iodinated contrast dye if you can. Your radio techs are going to be able to tell you that. Keep them hydrated, that's big. You can use acetylcysteine. When we get to drug overdoses, we'll talk about N-acetylcysteine with Tylenol. It is a drug that is very good at preventing free radicals, not the kind that we saw in the 60s, which you all missed, but the kind that are created and then they are very destructive. So we're going, by using that drug, we can do it orally, we can do it IV to decrease the production of those radicals. Anybody ever smelled acetylcysteine? Ryan has. What's it smell like?
It's like sour.
Okay, to me, it's rotten eggs. They've got a lot of sulfhydryl groups, and it's just a stinky, stinky, stinky medicine. That's why putting it in colas usually helps a lot. Okay, chemotherapy, cisplatin, and drugs in this, the vinca alkaloids, that's what this drug comes from. You know those beautiful little blue flowers that you have in your garden? They may be vincas. They can be white also, but they are vinca alkaloids. Cisplatin comes from that. They're very toxic to the kidneys, and you don't always get return to normal. So you may see this if you're dealing with patients who are on chemotherapy regimens that include that. It's a progressive renal impairment, and they're going to be watching it with the people that are on it. The one thing I would say, going over to page 10, the one thing to keep in mind here is once you take them off, they may not go back to normal. It usually will stabilize, which means it won't continue to progress, and you may see some improvement. But this is one of those where it doesn't necessarily go back to normal. Amphotericin, hello, amphotericin, my old friend. Okay, we've seen this one in pulm. Go back and look at your notes in pulmonary. I gave you a great handout on it. Okay? I did a whole section on just nephrotoxicity. Okay? To remind you though, common complication of amphotericin, especially, remember we had conventional and lipid-based. Okay, the conventional amphotericin, the old-timey one, first one out. That is the one that's hardest on the kidneys. It's usually dose-dependent, rate-dependent, formulation-dependent. So we're going to watch syncretin again. Here we look for a rise of not more than 2.5. That seems like a lot. A lot of times it's what you're dealing with. If you're having to use amphotericin, you usually have a mighty infection that you're trying to eradicate. And so they're going to tolerate here a little bit higher rise in that serum creatinine. Prevention, remember those. So the lowest dose that you can get by with, the slowest rate, hydrating them well before. We talked about pre-treatment, the salt loading. If you go back and read those, if they spark some of those memories, good or bad. Other nephrotoxins, really hard. This one is a hard, whenever I think amphotericin, I always think kidneys, because it's very common for it to occur. Another group that we talked about cyclosporin, but just briefly, cyclosporin is an immune depressant, an immunosuppressant. So you might see it with transplant, you might see it in some, yeah, if you're wanting to really, like with, we talked about ulcerative colitis, if we're really wanting to shut down the immune system quickly, we can use that, cyclosporin. The calcineurin inhibitors, Tacromulus is another one. We'll see it when we get into a lot of, we use it topically with skin lesions. Don't use it so much orally or IV. So this one won't be a very common one. The biggest problem with it, it's an irreversible. So that's the one where you really got to be attuned to that when you've got people that are on it. Dose related. Questions about those? Those are all ATN. Those are the big ones, the big guns. Let's look at hemodynamically mediated kidney injuries. This is ACE inhibitors and non-steroidals. If you look back, I wrote myself a note and then I ran right over it. On page 3, go back to page 3. Under pre-renal causes at the top, if you go down to the very last bullet, ACE inhibitors and ARBs, I think I was starting down one pathway and then I didn't finish my thought, that it doesn't constrict that efferent arterial, it vasodilates. The vasoconstriction comes from the angiotensin tube. So mark out the constrict and put vasodilator. Thanks for reminding me. You have some pictures in your handout. This one is in there. Again, going back to looking at the role of angiotensin 2 in maintaining glomerular pressure, keeps the hydrostatic pressure high within the glomerulus, keeps the driving pressure, GFR stays up. So with ACE inhibitors and ARBs, in some people, you won't see it in everybody, but in some people, you'll get enough of a decrease in glomerular filtration rate that their serum creatinine will just go way up because their GFR goes down. Happens soon, so that's one thing to keep in mind. It happens quickly, in a few days after starting. Usually will stabilize. Sometimes people will just watch it. But if it is a severe impact, you may have to take them off of it and move to another drug. We talked about the pathogenesis. I think everything up to the very last bullet on page 11. Consider stopping the ACE inhibitors. Sometimes we just leave them on it, depends on how high it goes. But if it increases and you take them off, then it may be that it takes. Let me see what I was trying to say. Oh, so if you can't maintain if you're having trouble with the serum creatinine and the hyperkalemia, what I'm saying there is move on. Okay, next picture kind of gives it to you again, shows you untreated effects of ACE inhibitors and ARBs. Again, efferent arterial. You see the ACE inhibitors are a little bit, they show it by picture-wise a little bit more effect of the ACE inhibitors on the efferent, but when they're looking at glomerular filtration rate, they're showing the greatest decrease is with the ARBs. So kind of lump those two together in terms of decrease in GFR. The non-steroidals and the COX-2 selective, we've talked about this one. I put this one in here just because it is so widespread use and patients can self-administer. So how do they present? Diminished urine output, weight gain, edema, urine sodium concentrations. Usually you're not going to measure those right off the bat. Fractional excretion of sodium is low. BUN, serum creatinine, potassium, blood pressure goes up. Again, it's because you are knocking out the prostaglandin's effects on afferent arterial. So you see what happens here, they're showing you a diminution of the GFR when you've got the non-steroidals. Again, doesn't happen to everybody. Those people are very dependent on it are the ones that will be most affected. Heart failure patients, common. Common is that they take a bunch of non-steroidal and they precipitate heart failure. So who's at risk? Those over 60. We're going to see this over and over again. So pay attention to these risk factors. Pre-existing kidney disease, liver disease, heart failure, dehydration, lupus, or those that are also using it with an ACE inhibitor, we're hitting both sides now, an ARB or a diuretic. Use the lowest dose, use something else, use it for the shortest period of time. So if you have to use it, monitor, but if you have other choices, move on. You don't really hurt, they will recover, so they don't usually injure their kidneys. We'll see that with other pain medicines, but not in this case. Questions about those? Page 14. I'm not going to test you on these. What I wanted kind of is show you other things that drugs can do. And you'll see the non-steroidals keep popping up in multiple places. So you can get obstructive nephropathies. You can precipitate kidney stones with some of the drugs. You can affect the glomerulus. We don't use gold very much anymore, but it was a drug that we used a lot in rheumatoid arthritis. Lithium, we use it a lot, or not a lot, but we still use lithium, especially in bipolar disease. So in psych, we'll talk about that. Acute interstitial nephritis, common with these drugs, but of all the kidney injuries, it's only about 2%. So it happens a lot with the antibiotics. So you see penicillins, Cipro, non-steroidals, proton pump inhibitors. Weird. I can't explain the mechanism, don't understand how they do that, but they show up in that list in loop diuretics. So chronic interstitial nephritis, they're cyclosporin again. Lithium, the body looks at lithium kind of like it does sodium. So we get into lots of problems with sodium regulation when we're using lithium. So it can cause a lot of kidney problems if people are on it long term. Papillary necrosis, there's the NSAIDs. Renal vasculitis, thrombosis, emboli. So I want you to kind of see the spectrum of things that drugs are going to do. That you don't have to memorize or learn that page. Okay. Questions? Yes?
Did gold actually work for rheumatoid?
It did. It did to an extent. But it has a lot of toxicities too. And so it's been supplanted by much better drugs at this point. It was our mainstay for a long time. Arousal is the trade name. Okay, treatment of, okay, so that's acute. So now let's move on to chronic. So chronic kidney disease. First, to determine what the stages are. So Dr. McNeil told me he talked about this, but he didn't really talk about stages. Oh, you did? Okay. Did he give it?
No.
Oh, so this was therapy.
Right after that.
Guest lecture.
Okay,
The guest lecture that flew through, you spent a little more time on.
okay. So that's where she tends to practice from. Okay, so you've talked about Krakoff and Galt. You've talked about how to estimate creatinine clearance. Okay, so it is a reflection of GFR, but it's not perfect. And that's because creatinine is not only filtered, but secreted. Okay. But they're close. It's close enough to give you some good guidance as to what's happening. Krakoff and Galt is probably one of the best in terms of just widespread. It takes into account age, weight, sex, and serum creatinine. So you've been exposed to that equation. If you look on page 16, there are calculators. They're on the internet. So you can use those. I want you to know the equation, though. It's just a good one to have at the bedside if you're just trying to get a good handle on what is your creatinine clearance. I do it all the time. From a pharmacist standpoint, I do not like to prescribe a drug unless I know what their renal function and their kidney function is. Now, you will go out there and see practitioners throw drugs at people and never even blink. Because most of the time, most people tolerate it well, but I'm telling you, you get into trouble eventually. So I want you to know that. You will calculate, I've got some problems throughout that will look at that. Let's take the first one. So use the Krakoff and Galt at the bottom of that page. Calculate the creatinine clearance for a 55-year-old man. Let's do the woman. Do the woman at the bottom. The 62-year-old female who weighs 64 kilos to have a recent serum creatinine of 3. What'd you get? What'd you get?
1996.
That's right. Anybody not get that? So age minus, or 140 minus age, times weight,
But she's a female, so you need to add in times the.
and 72 times serum creatinine, and then you're going to multiply it times 0.85. So it comes out to be about 20. I use it to eyeball, especially when I know that I may have to make a dose correction. Anybody's at 20, I'm telling you, a lot of drugs will have to be corrected. That's low. That's it's either stage 4 or borderline stage 5. Look at the next page. So these equations are based on, they just take a gob of people, thousands of people, between 18 and, I can't remember how high a Krakoff and Galt goes. They may have gone up to 80. They take all those people, and through the magic of math, they come up with an equation. As long as you are operating in those parameters, then the calculations usually are fairly accurate. They'll be close enough until you can get some kind of lab verification. People have unstable creatinines. These are no good. The variation is too much to be very accurate. This also, Krakoff and Galt isn't good for renal insufficiency. So for people who have creatinine clearances less than 60, this MDRD is a better calculator. It also, you can download it off of the net. So this is the one you should use if you're dealing with somebody as stage 3 CKD or greater. The other thing it took into account is it took into race. So it took into account African American. I know Dr. McNeil talked to you about that. When you get your creatinine, your estimated GFR on your lab, they'll give you, it's like white and non-white or something like that. I can't remember how they.
I think it's African American, not African.
Okay, so that's the, and they'll be slightly off. Now they're just slightly different. They're not huge differences, but so this one keep in mind for that population. Look on page 18. Limitations. It's good to keep these in mind. I am always just looking at what neighborhood am I living in with them if I don't know, okay? So I'm going to make decisions off of what I can get with a creatinine clearance, or I may be looking at a list of drugs and going, I see doses here that I know are too high for this person. I'm looking at an 80-year-old woman and she's got diabetes and they got her on full dose of certain drugs. So individuals with unstable creatinine clearances or concentrations, not a problem, or is a problem. People with extreme muscle mass. So creatinine comes from muscle. So these, if you got, when Krakoff and Galt did this, we didn't have the obesity problem we have now. So when you're dealing with people who are very obese, they have a higher muscle mass. They have to carry around a lot more weight. So it won't be as accurate for them. People who are bodybuilders, creatine supplements. Those can be a problem. Let's see. So populations not well represented. The elderly, blacks with higher levels of GFR, racial and ethnic minorities other than blacks. Now, is there a different Asian population? I can't tell you. There's not data collected that's been shown that it differs that much from there. Okay, so that was the first step, was determine what level of chronic kidney disease do you have. Second is, don't do any other harm. So keep them from harm. So don't use nephrotoxic drugs. Keep them in good volume status. Slow the progression of disease. So blood pressure, big impact on kidney disease. Diabetes, big impact on kidney disease. So when we get to diabetes, we've got evidence behind us that says if we do these things, we will slow down the progression of their kidney disease. We can't stop it, but we can slow it down. Okay? So that's what they mean by that. Lipid-lowering agents. Don't smoke. It vasoconstricts your microvasculature. It puts you at risk for more kidney disease. Treat acidosis. So COPDers tend to run chronically metabolic acidosis. Your kidney patients tend to run chronically metabolic acidosis. So treat that. That's what it's saying. Avoid high protein diets. Protein it's a lot of solutes load to excrete. So we're going to have them use less in order to take the burden off the kidney. Treat the complications. So high blood pressure causes kidney disease worsens high blood pressure. So controlling that. The anemia, we talked about anemia of chronic disease when we were in heme. And we talked about the importance of addressing iron deficiency anemia and then using the EPOs in order to improve their ability to produce red blood cells. Osteodystrophy. We'll get to that one probably in musculoskeletal, but what hormone is regulating that that calcium and phosphate? Parathyroid hormone, okay? You can't excrete phosphate and your calcium is either going up or down. Parathyroid hormone's like, what's going on? And it will make the bone reabsorb or it'll try to get the kidneys to excrete. So you get all kinds of bone problems with in chronic kidney disease. Okay, let's look over at the next page. Let's look at anemia. I've divided it into two things. So you've heard all this before, so you can go back and pick up that part of the heme. This is more, I've given you more in this handout than I gave you in heme. But you're looking at, do you have chronic kidney disease and you are not on dialysis, or you have chronic kidney disease and you're on dialysis. The treatment approach is a little bit differently. We use the same drugs, but we may dose them differently and dose them more frequently. The biggest thing, and I see it in family medicine, I saw it all the time, is that, because I dealt with a huge diabetic population, is kidney disease, their renal function is going down. They're doing fine though, they're operating well, they're usually at a stage 3. You ought to be looking for anemia. A lot of times they didn't, or they didn't address it. Usually there's so much else going on, it kind of goes to a low priority. Anemia often will fall to a low priority, especially if patients not complaining of any problems. So look for anemia, especially when the hemoglobin gets below 10. That's our key. The first thing we want to do always is correct the iron deficiency problem. Always. Giving them an erythropoietin drug when there's nothing for the body to work with or not enough won't get you the results you want, and you expose them to the toxicity of the drug. So we're always going to correct that first. Benefit versus risk. If you look down towards the bottom of page 19, there is bad stuff that happens when we use erythropoietin. So one thing you're going to see is there's limits. We watch how fast does the body respond, If it's raising hemoglobin too fast, we cut the dose down. If it's raising it above 12, we cut the dose down. So we don't overcorrect. We don't correct back to normal. Because the risk of death goes up, stroke goes up, and malignancies go up. Why? I have no idea. So for people who are on chronic kidney, who not on dialysis, or they're on peritoneal, then we may, if they need the erythropoietin, we're going to give it weekly or less frequently. These people have to go in somewhere and have it done. So if they are, and usually they're going to go to a cancer center or a blood center. So on the OU campus, everybody goes to Stevenson Cancer Center to get their erythropoietin. So you're imposing a burden on people when you start them on these drugs. They're going to have to go somewhere. They're also going to have blood drawn on a frequent basis. So with hemodialysis, if they're not on dialysis, usually we are going to dose them less frequently, like once a week or maybe every other week. You're going to treat their anemia probably a little bit differently than I would have taught last year, is that we're probably going to use IV instead of oral. One is, what do you remember about IV versus oral? IV's quicker, better tolerated. The big side effect of oral iron was what? Constipation, but GI upset. People just, it upsets their stomach. So we can get around that with IV iron. What's the worst thing that can happen with IV iron? Say it again. It's an anaphylactic, so she said infusion reaction, so it's anaphylaxis. So then again, it's usually given in an area where people have the ability to respond if someone codes. On page 20, it's a treatment of anemia in patients who are on dialysis. So here, what you'll notice is what we're going to do is we're going to give it more frequently. Usually for people who are not on dialysis, we'll give it sub-Q. That maintains, we don't have to burn up their veins, it's less painful, it's easier for somebody to give. But when we get to dialysis, we're usually going to give it IV, and we'll give it after a dialysis session. So here we're moving up to 3 times a week, if needed. So more frequently, IV administration. The one thing I want you to look at is goals. So the goal here, if you look under dose, is 11 to 12. We're going to start, we're not going to treat them until they get below 10, and we're going to move them up to 11 or 12. If they rise too quickly, we're going to cut the dose. And we're going to monitor them until they stabilize out. If you look under resistance, the most common reason why people don't respond is they haven't treated the underlying anemia. They haven't treated the iron deficiency. Page 21 brings back that information I gave you in heme. So just because of time, I'm not going to go back over it. Remember, there's 2. There's Poetin alpha, Proprint's the oldest one. Then there's Danacept or Randacept. It's higher potency, longer half-life. You got somebody who's a long way from a center, you might be able to justify the cost. Insurance may dictate that you have to get Proprint, especially if they can come in and have access to that. They're both effective. They both will do the job. Okay, what did you learn about phosphate binders? Oh, really? When you talked about chronic kidney disease, you have to talk about phosphate binders. Well, of course they don't like them. They're horse pills, meaning they're very big, and there's a lot of them, and they have to take them 3 or 4 times a day. Patients hate them. They have to take them. you really have to do a lot of work. So I saw a lot of dialysis patients because we did the diabetes. So, our dialysis unit never let them off the hook, never. So you just have to keep working with them, but it is hard. It is really hard. You have to appreciate the difficulty. If you look on over on page 23, I've given you a chart. So when you're looking at phosphate binders, you've got calcium binders, binders that contain calcium, and binders that don't. If they're low calcium and you're trying to bind phosphate, then you use the calcium-containing binders. Make sense? Yes. If their calcium is a problem and you don't want to raise it, then you use the non-calcium containing binders. So they're going to put these folks on a low phosphate diet. Dialysis diets suck. They're terrible. Usually the first thing that when I see a patient is come back, and all dialysis units will have a dietitian. They're all going to be seeing them. One is that they want them to keep their protein up. So nutrition is really important. They're going to put them on low potassium, low phosphate. So the next thing I usually hear from them is, what am I supposed to eat? Because everything we've taught them about a diabetic diet is greatly modified. Because they have potassium, they can't excrete the load anymore, and we want to keep the phosphate down. That way we can keep the binders down. You want to say anything?
Yeah, it was awful. And when I had to do a rotation in the dialysis unit, and a lot of the patients were not adherent to the diet because it was so restrictive. So
it's true, but you try to get them to move as much as you can. And I have always worked with just excellent dietitians. And, I mean, they know their stuff in those dialysis units. They know every trick in the book. So I'm calling them all the time. It's like, okay, I need to do this with their diabetes. How's this going to affect what you're doing? So look at the normal phosphate. Have an idea. It's not hard, 2.5 to 4.5. Okay. The higher it goes, what happens if your calcium goes up and your phosphate goes up? What happens? They're very attracted and they precipitate out. And they precipitate out in your tissue, your vasculature. So that's one of the reasons we have to keep it down. Is because otherwise, high calcium to phosphate ratio, boom, precipitates. It's kind of like hard water in Oklahoma. I had to clean out my hot pot. The house we lived in had hardest water. It took me 1.5 gallons of vinegar to get all of it out of there. It was just incredible. Okay, so phosphate, gotta get it down. Because the kidneys can't clear it anymore, and you got PTH that's just hammering it. So the binders are important. Look under common treatments on page 22. Diet will be important. There you got to have a dietitian that's working with them. Oral phosphate binders we talked about, and they can manipulate the dialysis for the patient if they're undergoing dialysis. Look at the goals of therapy. If they're not on dialysis, we're going to keep them in normal range. So you got to know what that is, 2.5 to 4.5. If they are on dialysis, then we try to keep them under 5.5. The calcium-containing binders, Tums, or calcium carbonate. Calcium acetate or Foslo is another common product. One that we're going to avoid, I've told you to use this one before, is calcium citrate. Don't use that salt. It increases aluminum absorption, and they can get aluminum toxic. Monitor serum calcium if they are on a calcium binder. Non-calcium binders, these are polymers. They attract the phosphate to them, bind it, and take it out of circulation. they're more expensive. So the insurance may be after you. Savelamir, Renagel, common one used. The other one is just a different salt. Iron-based binders, I have no experience with. I haven't seen them used in practice that often. I would have an idea about this. I think this is a good little table to look at. The biggest thing is pill burden. They may have to take 16 of those binders a day, and they're big, and that's why they hate them. And they're very constipated. Okay. Questions? I think what I'll do is I'll pick up vitamin D deficiency, and the other thing we will do is there's not that much left. But I'll do this at the beginning of class when we do UTIs and incontinence. There are a couple of problems in there as you calculate a creatinine clearance, and then it gives you the dosing table. If you look on page 28, there are some problems there. I give you a drug called Januvia. It's a drug we use in diabetes. And I give you, out of every package insert, the FDA, in every insert that is written, every drug that comes out has to have a monograph. And in that monograph, they will list, you can look it up on the internet, call it up, and it will give you the dosing administration based on renal function if it needs to be adjusted. What I want you all to do is calculate the creatinine clearance for those patients that I've given you. Pick the dose based on that chart. I guarantee you I will do that on the test. I am dead serious about paying attention to this because I cannot tell you how often I see it not done in practice. So I don't care if when you go out there your preceptors don't do this, you do it. Look at the renal function, especially in those who are high risk to have renal insufficiency. So if you will do those, if you'll look at those, I can finish this up at the beginning of the next time we meet. Okay, so Michelle, you'll get back to me about the test change, and you'll turn in your redos on Friday along with your GD. Any questions?